Hello, everybody. Happy Thursday. It is almost the weekend, and I have got my Thrive in 5. So, this week on social media, we discussed double lumen tubes, and then we also talked about some pulmonary pharmacology as well. So I wanted to talk a little bit more about double lumen tubes because it's kind of like, I don't know, can be a very tricky kind of subject until you do enough, like place enough double lumen tubes to understand them. So I want to talk a little bit about anatomy, and then we're going to talk about how you manage hypoxemia, hypoxia when you're using a double lumen tube, because it can definitely be tricky. So first thing I want to talk about is I mentioned on Instagram is that we usually always place a left-sided double lumen tube, regardless as if we're doing left-sided lung surgery or if we're doing right-sided lung surgery. And I wanted you guys to know kind of the reasoning why. So obviously you have your trachea and then you have the carina. And so if you look here on the right, like if you look at the anatomy of the right mainstem bronchus, it's shorter. So it's about 2.5 centimeters. It's also wider, and the takeoff angle is like 25 degrees. And if you look at the left side there, the left mainstem bronchus is a little bit longer. You see you have more space on the left-sided bronchus than the right, and the takeoff is like a 45-degree angle. So it's actually a little bit easier and safer to get a left-sided double lumen tube in versus a right-sided, just because of anatomy. And in general, when you start using double lumen tubes, I definitely would recommend really studying the anatomy of the bronchus, all that good stuff, because it will make your life so much easier when trying to understand these tubes. So that's kind of a brief overview as why I never have used a right-sided tube. Maybe you find someone who will, but most likely you're always going to be using a left-sided tube when you are putting these in. Okay, and I wanted to put this briefly in here about confirming position because it's hard. So once you place this tube in, you get it through the vocal cords, you turn it at a 90-degree angle and go down. Then you go down with a fiber optic scope to make sure you're in the right position. So at the bottom right of the picture, you'll see like that's the carina there, right? You have the right and you have the left-sided mainstem bronchus. Now, if you look at the top picture on the right, you can see the tube actually going in. And usually what you want to see is there's two cuffs, right? You have the tracheal cuff, which is white, and the bronchial cuff, which is blue. You want to be able to see that bronchial cuff just at that kind of bifurcation at the opening of the left side of the left mainstem bronchus. Okay, so I wanted to show you that picture, and I want you guys to look at a ton of pictures, whether it's YouTube, wherever, find some articles. I want you to really, really look at pictures of the anatomy because it's going to make your life, like I said, so much easier when you place these bad boys. So I did want to throw that in there really quick. And let's talk hypoxemia. So when you're doing these, it is depending on the patient's, body habitus, their medical history, how bad their lungs really are. It can literally be so hard to keep those sats up. Like sometimes if you have like 90, you're like, woo, like I made it, because it can definitely be super, super difficult. So always want to keep these patients on 100% oxygen throughout the case. Always be talking with your surgeon if you're having issues, because sometimes you might even have to reinflate that lung just to kind of get the sats up and make things better. But you're going to try these things first if you're having some hypoxia issues. So your dependent lung is a lung that's inflated, right? So whatever lung is down, because the surgical lung is going to be up, is your dependent lung, is your inflated lung. It's the down lung, right? So that lung is actually at risk at getting a lot of atelectasis. So what you want to do to fix that is you want to put some PEEP on. So I usually put, more than 5 of PEEP on. I usually don't go above 10, but you can definitely jack that PEEP up for a little bit to try to recruit some alveoli and get some oxygen exchange going. That's going to increase your ventilation perfusion because they're definitely going to be in a mismatch. And it's also going to shunt to the non-ventilated lung. Okay. Now, the non-dependent lung, which is going to be your up lung, which is going to be your deflated lung and your surgical lung. Now, that is going to suffer from hypoxic pulmonary vasoconstriction, which I know you guys have heard about that. We won't get into that now, but HPV is going to be going on, which is going to decrease your blood flow by about 50%, and you're going to have a right to left shunting of that blood, okay? So the best thing you can do is the double lumen tubes usually come with like a CPAP kit, and so you can actually hook a little CPAP kind of device to it and give some positive pressure. And then obviously that CPAP, that continuous positive airway pressure, is going to increase oxygen uptake, and it's going to increase your, arterial oxygen concentration, right? You can also increase your MAP, get the blood pressure up. You don't want it too high because it might be, going to cause bleeding, but you can increase that blood pressure to kind of get some more perfusion. And worst case scenario, you can actually ask the surgeon to clamp the pulmonary artery. I've never asked her how to do that before. Normally, if the CPAP doesn't work, like I said, you just kind of keep the lung inflated for a little bit, give the patient to kind of, recruit some alveoli, get some more oxygen floating around, and then you can deflate the lung again and hopefully continue with surgery. All right. So if you guys have any questions, let me know. This is definitely a really tricky subject. So if there's anything specifically that's tricky for you guys, let me know and I will help y'all figure it out. All right. So happy Thursday. Have an awesome weekend, and I will talk to you guys soon. See ya.